the best to everybody. Let's do it.
Yeah, all the best, everyone.
Yeah.
And of course, happy independence to each one of you. So we start with the first institute is GMC Aurangabad. The first team coming up, and the first speaker is Dr. Sarosh, and he will be talking on ophthalmic viscoelastic devices. So go ahead, Sarosh, please share your screen and also start the timer.
Yes, ma'am. Ma'am, someone is
judges ready? Are the judges ready? Nesargi has to stop sharing her screen. Yes.
Yes, ma'am.
Yes, we are ready.
Yes. So let's go ahead.
Yes, ma'am. Good morning, all. Myself, Dr. Syed Sarosh from GMC Aurangabad is going to present on the topic of ophthalmic viscosurgical devices. I'll be speaking about introduction, properties of OVDs, composition and classification of OVDs, application of OVDs, complications related with OVDs, and then take-home message regarding OVDs. I have no financial disclosures. First OVD to be developed was made up of sodium hyaluronate. OVDs are unique in a sense that they possess characteristics of both elasticity of a solid as well as the viscosity of a fluid. These are the four cardinal properties of an OVD. First being viscosity. Viscosity is the resistance to the flow of resistance to the flow. Higher the molecular weight, higher the concentration, there will be higher viscosity. Pseudoplasticity is the property with which a material can change its viscosity along with shear rate. Elasticity is the ability of a substance to return to the original shape after deformation, as in case of a rubber band. Coatability is the ability to coat a surface, which depends mainly on the surface tension of the OVD. An ideal OVD should be easy to infuse, should have high coatability, thereby protecting the corneal endothelium, should have high elasticity to absorb vibration during phacoemulsification, should retain and even under positive pressure in the eye, should be easily removable, doesn't interfere or incite any tissue reactions, and should be non-toxic. Classification of OVD, it is basically classified into three types: cohesive being with high viscosity, dispersive having low viscosity, viscoadaptive possess property of both cohesive and dispersive viscoelastics. Cohesion is the tendency to adhere to one another rather than to disperse. So cohesive OVDs have long chain molecules, higher molecular weight, and high viscosity, as seen in the figure on the right hand side. Whereas on the flip side, dispersive OVDs have short chain molecules with low surface tension, low molecular weight, and low viscosity. Example being hydroxypropyl methyl cellulose, and the figure is on the right side. Newer viscoadaptive OVDs are substances with high molecular weight and high concentration that contain fragile non-long chain molecules. Their physical properties are different from both cohesive as well as dispersive OVDs. Chelon 5 was the first viscoadaptive OVD to be designed rheologically. Composition-wise, sodium hyaluronate and chondroitin sulfates are the part of a cohesive viscoelastic, whereas HPMC forms the part of dispersive viscoelastic. Variety of application of OVDs can be seen. Mainly, it is used in cataract surgeries for protection of the corneal endothelium by coating the corneal endothelium. Then it is used in capsular rhexis to maintain the corneal dome and to prevent the rhexis runout and give surgeon adequate control over the surgery. Viscoexpression is another technique where we do nucleus delivery with the viscoelastic substance. Cohesive OVDs tend to rapidly extrude through the eye. Dispersive tend to remain within the corneal cavity. OVDs fill the capsular bag, thereby creating space. OVD is applied over the PCI oil, and then PCI oil is placed inside the capsular bag. Soft shell technique is a technique which was discovered by a Russian ophthalmologist named Arshinov. He used first a dispersive OVD to form a mass on the anterior surface of the lens. Then he used a cohesive OVD to create space and flatten the capsule. In this figure, we can see the purple line denoting the dispersive OVD to coat and protect the cornea, whereas the orange area is referring to the cohesive OVD. Ultimate soft shell technique is quite similar to soft shell technique, but in this, the core is made up of balanced salt solution. Intraoperative floppy iris syndrome, it is because of use of alpha blockers, which cause weakened dilator muscles. Viscoadaptive OVDs cause viscomydriasis, stabilizing the iris, preventing prolapse from the incision site. Instead of single OVD, soft shell and ultimate soft shell techniques are used. Corneal lamellar surgeries, OVDs along with air is used to expose the decimex membrane in dark procedures. OVD are used as a cushion to protect endothelial cells from femtosecond laser dissection. In glaucoma surgery, it is seen that intracameral use of sodium hyaluronate 5 post glaucoma surgery has been effective in reducing the early onset hypotony. In retinal surgeries, it is used in macular overgrowth repair. So complications, secondary glaucoma may occur. There may occur post-op IOP spikes, pseudo-anti-uveitis, post-op iritis hypopion, corneal edema may be seen, corneal decomposition, hypersensitivity reaction, crystallization of the eye surface, and cancer band-shaped keratopathy. So to summarize, OVDs are of three types: cohesive, dispersive, and viscoadaptive. They are used in various surgeries like cataract, IFIS, glaucoma, corneal and retinal surgeries, and complications associated with OVDs have to be kept in mind. Hope you enjoyed the session. Thank you for patient listening.
Yeah, judges can go ahead and ask a question.
Yeah. Which OVD will you use when there is you want to place a lens in a aphakic eye?
Sir, we'll use a cohesive viscoelastic so that it will form the space inside the bag, and then we'll
Which one?
sodium hyaluronate.
Sodium hyaluronate.
Hyaluronate. Yes,
Okay.
sir.
And why not HPNC?
Sir, basically, HPMC does not comes out easily. Aspiration wise, it may lead to post-op. It may have residual. It may go beneath the iris and settle down, thereby increasing the post-op IOP of the patient. Therefore, we will not prefer HPMC.
Okay. It is not biodegradable.
Okay.
Okay.
I would like to ask you one question. In case if there is retained viscoelastic in the eyeball post cataract surgery, how will the refractive error shift? What will there be any shift in the refractive error, or will there be emmetropia post surgery?
There will be shift in refractive error, ma'am. Slightly toward the myopic shift will occur.
Okay.
If we have to leave some viscoelastics in the eye, which is less troublesome, high density OVDs or low density? I mean, dispersive or cohesive?
Sir, cohesive easily extrude out through the anterior chamber, whereas dispersive tend to stay inside the anterior chamber. Therefore, dispersive will be more troublesome, and cohesives will be easily removed.
But you are closing the eye. Patient is not cooperative, and you have to close the eye. You have to keep the viscoelastics there. So which one you can afford to keep inside, and which one you have to clear it out as much as you can?
So cohesives will need to take out as much as we can. Some amount of dispersive can be kept inside the.
Okay. We are not able to see the timing, ma'am.
Yeah, I think he hasn't shared the timer. Did you?
Actually, it is. They have told the presenter has to tell the host.
Yeah. I had
to
told them, but I don't think he has started. But I had started my stopwatch, so it was okay. So next speaker, please understand all the hosts. Once you share your screen, you have to start the timer. Where is it seen on the screen? I cannot see one.
No, even it is not visible here as well.
Yeah. So maybe one of us can. We'll have to.
Madam, just to sample it. Excuse me, madam.
Yeah.
You can see the timer now. Just I have run a timer for your sample now. You can see on the right top.
Yes.
Is it seen?
Yes, it is seen now.
Okay, fine.
So whenever the session starts, we'll start the timer, madam. Whenever the speaker starts speaking.
So you will start, huh?
Yeah, we will start, madam.
Okay, fine.
I'm not able to view the timer. I think
I'm still not seeing it. Yeah, even I'm
Madam,
not seeing it.
I've started again. You can see it on the right.
Yes, ma'am. It's visible on the.
Okay.
It is visible only at the time of presentation.
Only at the time of presentation. Fine.
No, I've actually put it on now. You can see it on the right. Just for your
Yes.
Yes.
We're able to see, madam.
It's not seen on my screen. I don't know why.
We can't see.
No, we can't see.
Probably, I mean, you may have to update your Zoom. Anyway, presenters are able to see, madam, so it shouldn't be a problem.
Okay, fine.
But judges need to see.
Judges को दिखना
Yes.
चाहिए ना.
So the
Can you
update
click it somewhere?
I guess I'll put the timer on separately on the phone, I guess. That will be okay.
Can
That will be fine.
somebody announce at the end of the session whether they have completed or not?
Yeah, that can be done.
So can we start with the next speaker?
Yeah.
So I invite Dr. Pratiksha Solanki. She is going to talk on congenital ptosis. Again, she is from JMC Aurangabad. So Pratiksha, you can start the timer and are you sharing your screen? Yes. You are not seen. Are you seen? Is she seen?
Ma'am, I'm not able to start the time.
So numeratic people, can you start this timer? So she starts?
Started, madam.
Okay, start.
Good afternoon, everyone. Today I will be teaching about congenital ptosis.
Yeah, now the timer is seen.
Ptosis is abnormal upper eyelid if present in clinical anatomy. Three upper eyelid retractors are levator palpebrae superioris, MOS muscle, and frontalis muscle. Levator palpebrae superioris, being the chief retractor, is supplied by superior division of oculomotor nerve. Depending upon idiopathogenesis, congenital ptosis can be classified into simple congenital ptosis, in which dystrophy of levator muscle is the cause. Complicated congenital ptosis is due to oculomotor nerve palsy, Horner syndrome, or synkinetic ptosis. The evaluation of case of ptosis should start with history taking, ocular examination, and ptosis measurements. In history, ask for the onset and progression, ocular abnormalities like eye deviation or nystagmus, association of ptotic eyelid position with jaw movement. In ocular examination, start with head posture. Chin lift and head tilt are the signs of severe ptosis. In ocular examination, visual acuity and cycloplegic refraction are done to rule out associated amblyopia. Pupil size and reaction is checked. Ocular motility should be keenly checked, and it may be associated with restriction of superior rectus known as double elevator palsy as shown in figure, or there may be restriction of adduction and elevation in oculomotor nerve palsy. Ocular examination is incomplete without tear film function test and corneal sensation, as abnormalities may lead to post-operative exposure keratopathy. Now the important part is ptosis measurements. It starts with palpebral feature height. As shown in figure, it is measured from lower eyelid to upper eyelid in mid-pupillary plane. It should be measured in up gaze as well as in down gaze. Higher in down gaze due to lead lag is a classical sign of congenital ptosis. MRD1 or margin reflex 1 is the distance between corneal reflex and upper eyelid. It is 4 to 4.5 mm. It is more accurate in grading ptosis into mild, moderate, and severe. Margin reflex distance 2 is the distance between corneal reflex and lower eyelid. More than 6 is suggestive of lag of thalamus. Margin crease distance is a distance between upper eyelid and eyelid crease. Levator function test. It is very accurate in deciding the type of surgery to be undertaken. It is the maximum excursion of levator superiors from extreme down gaze to up gaze while we block the action of frontalis with eyebrow. It is excellent if more than 13 mm and less than 4 is poor. Signs of poor in child less than 4 mm are absent of lid crease, head tilt, and ellipse sign. In Marcus gun jaw winking, it is most common synkinesis associated with congenital ptosis. It is due to miswiring between fifth cranial nerve and oculomotor nerve. Surgical approach is based upon the severity of ptosis. Severe ptosis obstructing the visual axis, immediate surgery is undertaken. In mild to moderate cases, we can wait for 3 to 4 years. For mild ptosis, Muller's muscle resection can be undertaken. If levator action is more than 4 mm and mild to severe ptosis, levator resection is done. For moderate 23 mm of resection can be done. For poor LPS action with severe ptosis and associated jaw winking and blepharophimosis, frontalis sling can be done. It can be either due to fascia lata or silicone sling. as shown in this figure, silicone sling being used. Thank you.
Okay, judges can go ahead. Any questions for her?
That's
Yeah.
it.
Okay, go ahead.
So go ahead, please.
What is the disadvantage of a frontalis sling? Can you enumerate a specific disadvantage one can encounter because of the frontalis sling?
Sir, in frontalis sling, if we use synthetic material like silicone, it may cause the inflammatory reaction, and granuloma, suture granuloma is most common.
No, that is not the correct way. Okay. Anything else? Corneal drying because of the lagophthalmos, which it causes most commonly. Okay.
Okay.
Pratiksha,
Yes,
you
ma'am.
mentioned about checking the pupillary reactions while examining a patient. So why would you look for these direct and consensual reflexes? What are you ruling out?
Ma'am, in case of Horner syndrome, there may be meiotic pupil. And in case of oculomotor nerve palsy, we may have dilated pupil.
Okay.
विलाल भाईला म्हणा तुम्ही लिहा ना ते डोळ्याची तुम्ही लिहा.
Any more question?
Why elevation? Why evaluation of double elevator pulse is important?
Sir, because if it is present, then superior, first we should go for inferior rectus recession, and after that ptosis surgery should be undertaken.
Okay.
So can we go ahead now?
Yes,
Any more
ma'am.
question? Okay.
You can go ahead.
So we invite the next team that comes from MGM Hospital and Institute, Aurangabad. So I invite Dr. Naisargi Pambhar, and she is going to talk on corneal anatomy and its clinical significance. So Naisargi, start sharing your screen. Rest of you all can please mute.
Now, is it visible?
Please start the timer too.
Okay. Good afternoon. Today I'll be talking on the anatomy of the cornea and its clinical significance. Just a minute. I couldn't start. Can I restart it, ma'am?
See, there's an echo coming. If there is another, what you say, laptop or mobile on, then put it off. Leave
Yeah,
this
just a minute.
that. Yeah, and start.
Yeah. Okay, I'll start now.
Yeah, please do.
Good afternoon. Today I'll be talking on the corneal anatomy and its clinical significance. The cornea is an avascular transparent structure. It is densely innervated by the nerve endings. It is 0.5 mm thick centrally, and the thickness progresses towards the periphery. The refractive index of the cornea is 40 to 44 diopters, and it is 2/3 of the total refractive index of the eye. The normal size of the cornea is 10 to 12 mm horizontally and 9 to 11 mm vertically. But in conditions like megalocornea, the size of the cornea increases, which is more than 13 mm, And in conditions like microcornea, the size of the cornea may decrease less than 9 to 10 mm. In the conditions like keratoglobus and keratoconus, there is the change in curvature of the eyeball cornea, which leads to protrusion of the cornea, leading to a globular structure or a cone-shaped structure and altering the shape of the cornea. The sensory supply is given by the ciliary nerves of the ophthalmic branch of trigeminal nerve. The perilimbal nerve ring is supplied by the long ciliary nerves. In conditions like degeneration or dysfunction of the nerves, leads to delayed healing of the corneal injuries and development of the neurotrophic ulcers. I'll first talk about the individual layers of the cornea and significance, and then I'll correlate it surgically. Corneal epithelium, corneal clarity depends on the tight packing of the epithelial cells, resulting in the uniform refractive index and minimal light scattering. The epithelium of the cornea consists of 4 to 6 layers of cells, which includes the basal cells, wing cells, and surface cells, along with the tear film, which helps maintain the optically clear medium. And the palisades of Vogt is the area in the limbus where the limbal stem cells are present, which are necessary for normal homeostasis and bone repair. Any abnormalities of the epithelium can lead to recurrent corneal erosions or abrasions, which when gets infected leads to corneal ulceration. Bowman's layer, it is the layer which helps maintain shape of the cornea. If disrupted, it won't regenerate. Healing then occurs by fibrosis, which leaves behind a scar or opacity. The Rees-Buckler's dystrophy and Thiel-Behnke dystrophy are the dystrophies of the cornea, which involves the Bowman's layer. Stroma is constitutes 90% of the total thickness. The anterior 40% has twice the tensile strength of the posterior 60%, which plays a role in occurrence of corneal ectasia following deep Excimer, laser ablation, and LASIK surgery. In smile refractive surgery, lenticule is dissected from the surrounding cornea and then extracted, which may lead to corneal ectasia formation. And in refractive keratoplasty for breast biopsy, hydrogel lenticules implanted in the stroma alters the anterior curvature of the cornea and thus the refractive state of the eye. Also, an intrastromal corneal ring of PMMA material can be implanted for correction of myopia. Dua's layer, it is a thin acellular layer adherent to the Descemet membrane. It is strong and resists air dissection from the Descemet membrane during surgeries like deep anterior lamellar keratoplasty. Here, air is injected between the Dua's layer and the Descemet membrane in the type 2 bubble, and in the type 1 bubble, the air is injected between stroma and pre-Descemet membrane, which is more stronger. Descemet membrane is the most elastic layer. The small base line is the gonioscopic landmark, which defines the end of Descemet membrane. And descemetocele is the herniation or bulging of the Descemet membrane through a defect on the overlying corneal layers. DMD is a surgical complication which occurs during an intraocular surgery where the aqueous enters the pre-Descemet space, causing corneal edema. The endothelium is maintaining the corneal transparency by controlling hydration and maintain stromal hydration. In Fuchs dystrophy and in pseudophakic bullous keratopathy, the endothelium is involved. Lastly, this is the picture of the surgical techniques performed for corneal transplantation and shows the layers of cornea involved in the procedure. Thank you.
Okay, I request all the others to please mute. Dr. Sachin, please mute. So I request the judges to please ask questions.
What should we do about the timing part now? Because she was not able to start it and the timer was started early.
No, but I
think
had
we should
started
give her a benefit of doubt.
Sir, I had started the stopwatch, so she was very much in time, I believe.
Okay, that's fair enough.
Yeah.
I mean, I also was of the same opinion that she should not be.
Yeah, I can show the timer here.
Yeah, no problem. No problem. Yeah.
Okay.
Thank you.
Which is the important, which is the layer which is important for transparency of cornea?
So stroma is most helpful for maintaining the transparency because of the lamellar arrangement of the collagen fibrils, which helps in less diffraction and interference of the transmission of light rays.
No, because the endothelium, if the endothelium is not in a correct shape or health, this stroma, even if it is in a correct shape, it will not have the transparency. It will definitely become hazy. Okay.
Naisargi, can you explain the epithelial regeneration? How does it take place?
So, ma'am, the limbal stem cells, they help in epithelial regeneration. The basal layer of the cells migrate from the limbus to the basal layer of the cornea, corneal epithelium. From their differentiation of the cells occurs, they progress towards the outward side, to topwards. They change to wing cells, then gradually to squamous cells, and then they are helpful in regeneration. It takes place 7 to 14 days. In 14 to 15 days, the entire layer of the cornea's epithelium is replaced.
Okay. Okay.
What is importance of Dua's layer?
Naisargi, you can show your video, please. Start your video.
Dua's layer is the just above the Descemet's layer. It helps in it is a strong layer. It helps in dissection during the procedures like deep anterior lamellar keratoplasty. The air bubble is injected to separate the layers, and from there the keratoplasty procedure is done. So air bubble is injected. If it is injected between the stroma and the pre-Descemet layer, then it is the type 1 bubble. It is more stronger. This type 2 bubble, which is injected between pre-Descemet and Descemet, it is little weaker and there are more chances of perforation on its insertion. So it is like a landmark for the keratoplasty procedures.
Okay, good.
So can we go ahead? Judges, can I go ahead?
Yeah,
Yes,
go
ma'am.
ahead.
So I invite Dr. Zainab Vaid from MGM to start her talk on vitreous substitutes. I request all the speakers to put your video on, and the tech support people, please start your timer as soon as the speaker starts her first slide. Go ahead. Share your screen. Yeah.
Hello. Hello.
Yeah, please go ahead. Start.
Okay. Yeah. Vitreous is a gel-like substance which is 4 ml in volume and has an optical, structural, barrier, nutritional function, and containing of proteins, ascorbic acids, and glycosaminoglycans. The vitreous substitutes are used as an adjunct in various vitreoretinal surgeries having retinal detachment with the following conditions, along with various other functions like expanding or replace the vitreous volume, replacing opaque vitreous, provide internal tamponade, and mechanically separate epiretinal tissue from the retina. An ideal vitreous substitute should be optically clear and transparent, is insoluble and easy to manipulate during the surgery, has adequate surface tension, easily available, stable, and its refractive index and density is similar to the vitreous. The various vitreous substitutes are classified into mainly gases and liquids with newer advancement of hydrogels. Air was first used by Ohm in 1911 for retinal surgeries, but as it diffuses quickly, its use is limited to fluid air exchange during the vitrectomy. The other two gases are sulfur hexafluoride and perfluoropropane. SF6 expands to double its size within 1 to 2 days and lasts for 1 to 2 weeks with its concentration with air 40% and a non-expanding concentration of 18%. While C3F8 expands 4 times its volume within 70 to 96 hours and lasts for 6 to 8 weeks with a concentration with air 17 to 20% and a non-expanding concentration of 14%. These gases are used in pneumatic retinopexy, macular hole surgery, ERM surgery, and retinal detachment with minimal proliferative vitreoretinopathy. Here is a picture of gas implantation where you can see a small retinal tears and gas is injected as a tamponade, and then laser photocoagulation is carried out, which further and then there is further diffusement of the gas. The various limitations are increase in IOP, gas-induced cataract, and corneal decompensation. After the gas injection, the patient is asked to avoid high altitudes and air travels and keep a face down position. Also, the gases do not provide a tamponade for longer periods. Silicone oil is a highly dense, is a high density and high surface tension with low specific gravity vitreous substitute. Oils with several viscosities are available, of which 1,000 and 5,000 centistokes are most commonly used clinically. Silicone oils are to be removed 3 to 6 months after their installation. The various indications include complicated retinal detachment with PVR, RD with inferior break, retinal resurgery of retinal detachment, and endophthalmitis. Silicone oils have an advantage over the gases as air travel is travel by air is possible, and they have an extended tamponade and support to the retina. But at the same time, it can cause band-chip keratopathy over the cornea, cataract formation, and increase in IOP, and they also undergo emulsification, which leads to a formation of an inverse hypopyon in the anterior chamber. Perfluorocarbons are high specific gravity liquids, of which perfluoro N-octane is the most preferred. They act as adjuvants in surgeries to remove dislocated IOLs, as they provide a third hand in removing them by floating them away from the retinal surface. Denseron 68 is a solution of F6H8 and 5,000 centistoke silicone oil used in patients with complex inferior retinal redetachment where standard procedures have already failed. Hydrogels are synthetic polymer networks, and smart hydrogels create a 3D structure, but they are difficult to sterilize and cause activation of the immune system, and they are still under research. Foldable vitreous implants, magnetic silicones, and vitreous regeneration with controlled hyaluronide proliferation are under research as future vitreous substitutes. Thus, to conclude, use of air is now limited to fluid air exchange, and while the other gases are used in surgeries with simple retinal tears, also C3F8 provides a long-term tamponade, while the liquids are used in complicated retinal detachments. Thank you.
Yeah, judges, please. So I think she has upshooted her time.
Yeah. What are the complications of silicone oil if it is kept beyond what point do you feel that the silicone oil will give some complications, and which complications you expect?
So maximum time we can keep is up to 1 year, and
Okay.
the silicone oils have a property to emulsify. So gradually they'll form small droplets in the vitreous, and then they can even touch in phakic patients they can touch the lens surface and cause cataract formation, while in aphakic patients they may touch the endothelium of the cornea and may lead to corneal decompensation as well as band-chip keratopathies.
Okay.
What is the importance of fluid air exchange into the in the surgery?
Sir, initially an infusion pump is attached so that it will drain out all the vitreous after a vitrectomy, and then air is injected, which leads to because the air leads to outflow of the fluid, which was initially injected as infusion, like the balance salt solution, etc. Now this air will lead to pressure over the retina, and it will cause a tamponade. Now, after putting a tamponade, the retinal tear which has happened will get unfolded, and then you can carry out a photocoagulation. After this photocoagulation is carried out, to maintain this tamponade, you can inject high density vitreous substitutes like silicone oil, which has a long-term tamponading property.
Good.
For PFCL and silicone oil, why is silicone oil preferred over PFCLs?
Ma'am, silicone oil is a high density and it has higher viscosity. So in PFCLs, there can be complications that it might diffuse into the retinal tears, which can be still there. So it may lead to further reed detachments.
PFCLs are heavier than silicone oils, so the long-term toxicity is more with PFCLs as compared to silicone oils. Okay.
Can we move ahead?
Yes.
Thank you.
So judges, please note that this was the team 3, right, which has come up. So you have to either you can write the names or write a college name. Okay, so this was MGM team that presented. Now we invite Sri Ganpati Netralaya team from Jalna. So Dr. Radhika Dara to start her presentation to talk on contraindications for laser surgery. Dr. Radhika, please share your screen. Is she not here? Dr. Radhika?
अरे मुझे पता है क्या हर एग्जाम से एक है मतलब
Dr.
उनका
Radhika,
कितना
are
सारा
you there?
पर सेशन 1 2 3 उसमें सब में
Please mute your instruments, others. Dr. Radhika, are you there? This is the third call. Is Dr. Dilna here? Dr. Dilna, I can see you.
Their message has come that they're unable to connect.
So they've sent a message.
We sent a WhatsApp message just now.
Okay. Then we go on to the next team. Can we?
Yes,
Judges?
Yes, ma'am.
Yeah. So
Go ahead with the other team.
yeah, we go ahead with the other team. So the next team is again GMC Aurangabad. So I invite Dr. Sonali Bagade. She will be talking on dyes in ophthalmology. So share your screen. And tech support people, please start your timers.
Good afternoon, everyone. 12-year-old child presented in our OPD with accidental lime injury. So to know the extent of epithelial defect, we have to stain it. And after staining, we can see the exact extent of the epithelial defect. And what we used here is one of the ocular surface dye. So I will be talking today on dyes in ophthalmology, in which we will cover ocular surface dyes and vital dyes for intraocular surgeries. Ocular surface dyes mainly stain the disease surface, and the staining is directly proportional to the severity of disease. What we used in the first case was fluorescent dye, and it is orange in color, water-soluble dye that adheres to basement membrane. It gives yellow-green fluorescence on cobalt blue filter, and it is available in strips and solution. It is mainly used for epithelial integrity, Sidders test, nasolacrimal duct patency to visualize mucus strands. It is also used in contact lens fitting, in Goldman applanation tonometry, in tear film breakup time, and IV fluorescence 2 ml of 25% is used in fundus fluorescence and angiography, in which we have to keep emergency cart ready. Then coming to rose Bengal, it is same to fluorescent, but it stains the dead and devitalized cells, and its activity is blocked by tear film. It has the antiviral activity against HSV1. It is used mainly in dry eye disease, as seen in the picture, which shows the classical triangular area of staining, which shows the dry eye disease. It also used to stain dysplastic cells and herpetic corneal epithelial dendritis and superficial punctate keratitis. Coming to Lysamin green, which is similar to rose Bengal stain, but it is less toxic and green in color, used in dry eye disease and to stain the mark line. Then it is also used to stain the leading edge of viral proliferation of dendritic ulcer. Sulforodamine B is also used to detect the epithelial defect, but it is orange fluorescence and excited by green light, and it is very rarely used. Till now, we have seen that fluorescein and sulforodamine B have the similar mechanism of action, but rose bengal and lysamine green stains the dead and devitalized stains, whereas rose bengal is more toxic. Coming to whiter stains for intraocular surgeries, in which trypan blue and triamcinolone acetate used in both anterior and posterior segment surgery, in which trypan blue is most commonly used in anterior capsular staining in cataract surgery, and it is non-toxic to corneal endothelium. It is also used to remove, to visualize and remove posterior stroma in deciment stripping, to stain the Tennant's capsule and to stain the epiretinal membrane. Coming to gentian violet, it is more toxic, hence it is only used for marking in corneal surface. Toluidine blue is used in conjunctival surgery and to mark the precise location of squamous cell tumors. Triamcinolone acetonide is binds avidly to vitreous gel and used in anterior and posterior vitrectomy. But it increases IOP, increases inflammation, and accelerates cataract and remains there for 40 days. Indocyanine green and infracyanine green used to stain the internal limiting membrane and in imaging choroidal vasculature and in ICGA. Brilliant blue green is used to stain internal limiting membrane in macular hole surgery, and it has the enhanced functional recovery of retina than indocyanine blue. These are my references. Thank you so much.
Judges, please go ahead.
Nice presentation as such. Very good.
Thank you, sir.
For conjunctival tumors, maybe for OSSNs, is there any dye which can be used?
Rose bengal dye can be used as it stains the dysplastic cells also.
Yes. Okay. Is there any toxicity which is observed in case of a trypan blue which is used in the anterior chamber?
It actually if we do not wash the dye then dye neatly, then it will block the trabecular meshwork and it can increase the IOP post-op.
Okay.
Can you talk about the pattern of staining in herpetic lesions with rose bengal, lysamine, and fluorescein?
Yes. As we have seen, the fluorescein actually stains the whole of the dendritic ulcer, but rose bengal is used to stain the edges. So the leading edge where the viral activity is more is stained by the rose bengal, and similar with the lysamine green, which stains the edges of the dendritic ulcers.
Okay.
While forming the anterior chamber at the end of cataract surgery, if the chamber is not forming, can you take help of any of the dyes? In what way?
We have to see if there is any posterior capsular tear. So if the pupil is not regular, then we can use the triamcinolone acetonide as it forms the crystal on the vitreous, and we can clearly see if there is any vitreous coming and it is increasing the pressure and not forming the anterior chamber.
If there is no vitreous disturbance, no PCR in that case?
We can use the trypan blue, but it only helps if there is any leak. If there is any leak, we can grossly see it on the microscope.
Correct. And there we can place a suture.
Yes.
So should we go ahead?
Yeah, go ahead.
Okay. So
Thank you so much.
next we will invite Dr. Vaishnavi Bhangadia, and she is going to talk on differential diagnosis of a limbal mass. Dr. Vaishnavi?
Yes, ma'am.
Yeah, please share your screen. Tech people to please start the timer. Go ahead.
Good afternoon, everyone. I'm Dr. Vaishnavi from GMC Aurangabad. Today we are going to talk about the differential diagnosis of limbal masses. Let's get started. After seeing these images, questions come to our mind, what could be the diagnosis? So these are the limbal masses. These are the different limbal masses which we are going to see, which includes pterygium, pinguicula, limbal dermoid, and so on. So before starting that, first we can see how will you evaluate the limbal mass. For that, history. Then in history, age of onset, duration, slow or fast growing, associated symptoms, history of trauma or surgery. Now let's move to the first most common limbal mass, that is pterygium. It is the vascularized granulation tissue. Risk factor being chronic UV exposure. Lubricating eye drops can be used, and excision with conjunctival autograft and amniotic membrane graft is used to reduce the recurrence. Chemotherapy with mitomycin C is used. In this image, we see a similar looking yellow nodule, which is avascular, suggestive of pinguicula, and simple lubricating eye drops can be given. This is the another inflammatory lesion, which presents as a nodule with superficial hyperemia, suggestive of flectinular conjunctivitis, which is the delayed hypersensitivity reaction to foreign antigens like Staphylococcus aureus and Mycobacterium tuberculosis. Topical steroids can be given, and in cases of recurrence, tetracycline is given. Another benign inflammatory lesion, which presents as a nodule, which is freely movable with superficial vessel dilatation, which blanches with 10% phenylephrine, suggestive of nodular episcleritis. Topical steroids and non-steroidal anti-inflammatory drugs are given. In this, and then another inflammatory lesion, that is nodular scleritis, which presents as deep scleral inflammation with hyperemia, secondary to autoimmune disorders, and is present as the painful immovable nodule. Treatment includes topical steroids associated with systemic non-steroidal anti-inflammatory drugs and systemic steroids. Now, this is the image of the child, which shows a dome-shaped nodule at the inferotemporal quadrant, along with the hair follicles, suggestive of limbal dermoid. For treatment, excision and lamellar keratotomy is done. Another pigmented limbal mass, it is the conjunctival nevus, which is the single flat pigmented patch, and seen in the adolescent age group. Treatment is just observation. Another pigmented mass is primary acquired melanosis, which shows variable pigmentation, and it is the most common precursor for malignant melanoma. For treatment, biopsy, wild local excision with double freeze Thaw cryotherapy is done. Now, this can be the most dangerous nodule, which is present as darkly pigmented mass at the limbus, which is fixed to episclera and is vascularized and is vascular. It shows metastasis and it's seen in elderly population, which is conjunctival melanoma. For treatment, wild local excision with double freeze cryotherapy is done. Topical mitomycin C is given. Enucleation and exenteration is done. Now, this is the image which we commonly encounter in our OPD. This limbal mass is the abnormal growth of dysplastic squamous cells, which may appear gelatinous, leukoplakic, or papillomatous with associated superficial feeder vessel, as can be seen in the image. And histology is important to diagnose it. In the first histological image, we can see dysplastic cells involving a whole thickness of epithelium, suggestive of carcinoma in situ, and another image showing deeper proliferation, that is squamous cell carcinoma. For treatment, wide local excision with double thoracic cryotherapy at the margin is given. Topical chemotherapy with mitomycin C and interferon alpha 2b is given. Orbital involvement for orbital involvement exenteration is done. This is the purplish nodule at the limbus with vascularization in the retroviral positive patient suggestive of Kaposi sarcoma, and antiretroviral therapy with with excision and local chemo and radiotherapy is given. In summary, it is important to differentiate masses, whether it is limbal or whether it is benign or malignant, through thorough history, clinical examination, and investigations, which also helps in early diagnosis and management. Thank you.
Yeah, so judges.
How will you differentiate between a pingvicula and a OSSN? Whether and where will you treat? And which lesion will you treat?
Sir, the pingvicula will be a patient might present with just irritation, and it requires only lubricating eye drop. And OSSM present may present with the nodule which with superficial which we can examine and will see the superficial feeder vessel, and the mass will be growing rapidly growing.
Will that staining help in this differentiation of these two lesions?
Yes, sir. Yes, sir. Yes, sir. Rose Bengal staining can be used. It will stain ocular surface squamous neoplasia.
But it will not stain pingvicula.
Yes, sir.
Okay.
Any imaging studies you will do to rule out ocular surface neoplasias and other limbal masses?
Yes, ma'am. Anterior segment OCT can be done. Then ultrasonic UBM can be done.
Why?
Ma'am, it will show if there is involvement of ocular codes. Extension of ocular codes can be.
Sorry, I didn't get you. Can you repeat your answer?
Ma'am, ultrasonic biomicroscopy will help to detect us involvement of eyeball codes. Involvement of eyeball codes.
Okay, okay.
Codes, she says.
Okay.
Was she on time?
She was a bit up mark.
Okay.
15 seconds or so. Is that all? Dr.
Yeah,
Saket?
When do we intervene in case of OSSN? Whether every lesion is to be excised?
Sir, if it involves more than 4 clock hours of the limbal area.
Okay.
So we go ahead. Can we go ahead?
Go ahead.
Yes.
Yeah, so we now would like to invite Shri Ganpati Netralaya team. So first, are you connected? Well connected now? Hello. So I invite Dr. Radhika Dara to talk on contraindications for laser refractive surgery. Please share your screen.
Yes, ma'am. Ma'am, I'm sharing my screen to Dilna.
Okay, no problem. Go ahead.
So, identity.
Tech people, please start the timer. Go ahead, Radhika.
Wait a minute.
Please put up your slideshow.
Yes, ma'am. Hello everyone. I am discussing here the
Slideshow, please.
contraindications of the laser refractive surgery. Let us hear a yes, ma'am. Let us hear a story of the 26-year-old female who underwent refractive surgery 2 years back for cosmetic purpose, presented with blurring of vision since 3 months. On refraction, she was found to have compound myopic astigmatism. On further examination, topography suggested of the ectatic cornea. So it was the case of the post-classic ectasia. So we don't want such a complications. So we need to evaluate the patient operatively only. Reshape the curvature of cornea. And can be done through surface ablation and PRK and the LASIK. Because everyone is a good candidate for laser refractive surgery, there are several conditions we disqualify from the procedure. So what are the prerequisites? Age should be greater than 18 years, stable refraction for last 1 year, and current FDA approval is up to 7 diopter. And there should be sufficient residual stromal bed thickness of 250 to 300 microns. The contact is soft contact lens less than 10 days prior to surgery, and if it's hard contact 2 to 3 weeks prior to surgery. Counseling is the most important part. Patient should be male motivated because unmotivated patient is the most common cause of the dissatisfaction. And the surgeon should give the realistic expectation before the surgery. Dystrophies which are visually significant, and we need to rule out the severe dry eye, acute uveitis, significant cataract, and uncontrolled glaucoma. So other contraindication in systemic includes uncontrolled diabetes mellitus and connective tissue disorders, which will lead to poor wound healing and lactation. There are possible changes in refraction and corneal hydration status. Medications includes patient using isotretinoin post-operatively. Related contraindication includes blepharitis, dry eye, chronic eye rubbing, retinal pathology involving macula, patch, retinal surgery, and as well as amblyopia, diabetes mellitus disorder, systemic malignancies, and medications such as sumatriptan and hormone replacement therapy. So what is the importance of a refractive workup? Is to identify who should not have the refractive surgery. Standard workup for preoperative ophthalmic examination includes the visual acuity, refraction, external examination, and direct fundus examination. The most importantly, topographic and tomographic analysis, keratoconus. Pachymetry to ensure minimum residual bed thickness of 250 to 300 microns, and Oxford device measures the corneal throughout the corneal thickness. So, in conclusion, being is LASIK not for me. If you are unrealistic expectations, you are not a risk taker. It will jeopardize your career. And if you are contact sports and if you are not an adult, especially for the refractive surgeon, one should know when not to operate. Thank you.
Okay. So your internet is still very poor, but go ahead. So for the next speaker, please put up a hotspot or something, right? So I request the judges to please go ahead.
Yes, talked about LASIK, but what about the surface ablation part? When would you
surface ablation
not
part,
advise
PRK.
any procedure like a surface ablation? Also, in which cases you will not advise them? I'm not talking of LASIK.
If there is in PRK, the surface ablation surgeries are PRK, LASIK, and E-LASIK. So
Surface
in case
ablation
of
is
the
not
corneal
LASIK.
dystrophies,
LASIK is
if
not
we
surface ablation. Wrong.
LASIK,
LASIK, okay.
laser assisted subepithelial
That I know. Yeah, okay. Now, when will you do it and when will not? You will not do it. In which condition? Okay, I'll give you an example. There is a patient of myopia of -7 diopters, and he is having K reading of 39 and 38. Would you go ahead with surface ablation? Even if the pachymetry is good, say 530. Because the pachymetry is good, so it is possible to do a surface ablation. So will you do it?
No, sir.
Pardon? He is having a good pachymetry.
No, sir.
Okay. Why not?
Because it is a flat
Okay.
cornea. Because of surface ablation, it may
Tell me the reason. Okay. I can understand you are saying no, that's correct.
post-operative
That is correct.
complications, ectatic disorders.
No.
Hmm.
This is not the question of ectasia.
Surface ablation
It
leads
is the
to
question of extreme flatness, extreme flat cornea you will be creating after the refractive surgery. That is the answer. That is the answer. You will be creating a cornea of 31 diopters, which is very, very flat, and it will give you a very, very bad visual disturbance in the future. So you will not resort to any surface, any procedure, refractive surgery procedures, if the corneas will be after the surgery, there will be less than 35 diopters. Okay. Okay.
yes, sir.
What are the systemic contraindications for refractive surgery?
Uncontrolled diabetes mellitus and the connective tissue disorder.
Why?
Because in diabetes mellitus, it will lead to poor wound healing.
Okay.
And post-operatively, it may cause the epithelial defects, which is not healing.
Okay. And what about the autoimmune diseases?
It is a relative contraindication.
Okay. Why?
Because after controlled autoimmune diseases, one should consult the primary physician whether the patient can be operated for refractive surgery or not.
But you are the operating surgeon, so whether you will take the decision or not.
Whether the disease is inactive or not during the. If it is controlled, then we go for refractive surgery. And patient, if he's on medications and control.
Even autoimmune diseases need to poor wound healing, and there is a chance of high dryness in these patients, so it is a relative contraindication. Okay.
Why do we avoid refractive surgery in pregnancy?
In pregnancy, there is a hydration of the cornea, which will lead to instability of the refraction.
Okay. Did she finish in time?
Yes, sir. She was in time, before time, actually.
Okay.
Saki?
Okay, go ahead. Now, next.
Okay.
Thank you.
So now I invite you stop sharing your screen. I invite Dr. Dilna. She'll be talking on optic disc examination in glaucoma. Share your screen, please. You have a poor internet. You should take some hotspot or something. Huh? It's not being shared.
Ma'am, I
No?
have already shared.
Yeah. So tech support, please start
Hello?
the timer. Go ahead.
Hello?
Go ahead, Dilna.
Hello?
Go ahead. We are hearing you.
Ma'am, I am unable to see. Good
Stop.
afternoon, everyone.
I'll be teaching you about optic disc evaluation in glaucoma. And I'll be dealing with optic disc and its variation, optic disc changes in glaucoma, and the key points in its evaluation. Optic disc is the visible part of optic nerve. It can be evaluated through direct ophthalmoscope, indirect ophthalmoscope, and slit lamp biomicroscopic, it being the ideal method. A normal optic disc is having a vertically oval in shape with a horizontally oval cup with a vertical diameter of 1.8 mm and a horizontal diameter of 1.7 mm. The neuroretinal rim is pinkish to orange, with the thickest being the inferior, followed by the superior, nasal, and the temporal. The size less than 1.5 mm is considered small disc, and the greater than 2 mm is considered large disc. Any disc shape variation doesn't follow isn't true. It is usually violated in glaucoma. A retrieve image is used to identify the true extent of the cup. How to determine the cup margin? In order to determine the cup margin, the vessel should be traced along the optic disc wall and optic cup wall. The second kink in the vessel should be noted as the cup margin. The retinal nerve fiber layer is ideally seen with red-free filter. Peripapillary area has two zones, alpha zones and the beta zone, and beta zone is ideal for evaluation in glaucoma. This changes per se in glaucoma. This gives the most reliable and early evidence of the glaucoma and helps to distinguish glaucoma from other optic nerve pathologies and help to monitor the progression. There are various signs of glaucoma. The main should be on scleral rim, neuroretinal rim, retinal nerve fiber layer, peripapillary atrophy region, retinal and disc hemorrhages. The scleral rim should be evaluated. It gives the idea about the optic disc margin. Optic disc after scleral rim, we should evaluate the neuroretinal rim thickness, notching, and its color. Parallel greater than cupping will give us cup disc ratio greater than 0.6 and an asymmetry of 0.2 should be giving us a suspicion of glaucomatous disease. Deepening of the cup is indicator of progression of the disease, and the retinal nerve fiber layer slit defect and wedge defect can be better visualized with retinal red-free filter. Indicates a thin adjacent neuroretinal rim. Presence of optic disc hemorrhages is a poor prognostic indicator. Nasalization of the vessels are the key vascular changes. The key points in optic disc evaluation in nutshell is to observe the size and shape of the disc, look for the neuroretinal rim thinning pallor and any retinal nerve fiber beta zone, and any optic disc hemorrhages. Be aware of normal optic disc finding, glaucomatous and non-glaucomatous disc changes. Always evaluate every disc as if it is a glaucomatous disc and document disc findings properly. Monitor any progression and correlate disc findings with other parameters in the glaucoma evaluation. The article by Monica Gandhi and Sunita Dubey is a good read. Everyone can go through the article. Thank you. Ma'am, I was unable to share my video.
What we could see everything. That was okay. Yeah, so over to you, judges.
Oh, what is the cup disc ratio which you will consider to treat a case of glaucoma, even if the patient does not have any other findings, which is the cutoff line sort of to treat?
Cup disc ratio greater than 6 should give us a suspicion of glaucoma, and we should evaluate the patient for 0.6. 0.6.
Okay. And in case of a normal,
and then asymmetry between the two discs of greater than 0.2.
Okay. And what is is there any sign of kinking of blood vessels which you will consider in case of any other in case of absence of any other sign of glaucoma?
Nasalization of the disc vessels, bayoneting of the vessels, or bearing of the circumlinear vessels should be considered as a
In
early
which area?
vascular changes
Temporal
in
or nasal? In which area?
nasalization
Temporal?
of the disc vessels.
Okay. Good. Okay.
What is the alpha? and the
Usually, optical disc vessels arise from the center, and nasalization of the vessels indicate that the cup size is increasing and the vessel has shifted to nasal side.
Yeah. Okay. Correct.
What is the alpha and the beta zone, and what is its significance?
Alpha zone indicates is just seen adjacent to the beta zone is seen just adjacent to the scleral rim, and alpha zone is just adjacent to the beta zone. Alpha zone is irregular hypo and hyperpigmented area, and beta zone shows atrophy or RPE and chorioretinal thinning, and encra and adjacent thinning in the neural rim.
Okay. Okay.
In a patient who is on treatment for glaucoma, comes for a regular follow-up, and then you see optic disc hemorrhage in one of the eyes. What is the significance? What will you do?
It indicates there is progression of the disease, or there is diurnal variation in the IOP control, which we have control medication. The patient should undergo diurnal variation test. Maybe the anti-glaucoma medication which we have given at that time, the IOP is normal and the IOP is fluctuating during night times. Usually disc hemorrhages are usually seen in normotensive patients or ocular hypertension. It's a sign of progression of the disease or worsening of the disease.
Okay.
Can we go ahead?
Yes, ma'am.
Yeah. Please go ahead.
Yeah. So please stop sharing your screen, Dilna. So for the fifth team, I would like to invite IMSR Badnapur team. Invite Dr. Bansi Wade to talk on refraction in children.
Hey, maybe to share.
Please share your PPT, Dr. Bansi. Share your screen. We see that you all have a good internet connection. If not, you can take mobile hotspots. Dr. Bansi. Can you share, Dr. Bansi? Dr. Bansi, are you connected? Yeah. Yes, please share your PPT.
Hello.
Yeah, you can share your screen.
Oh, yeah, so I'm so sorry, I had some Wi-Fi issues. Okay. So good afternoon, everyone. Happy Independence Day.
Share your screen.
Yes, ma'am. Okay. So today we'll be discussing the topic.
Start your timer. Yeah, please. Go ahead.
Okay. So the human eye undergoes dramatical anatomical and physiological development throughout their infancy and early childhood. Infants have a wide range of refractive error. Mostly about 90% of them are hypermetropic by about +3 to +4 diopters, while 5 to 10% can be myopic. They go through a process of emetropization by which they achieve their ideal refractive status. Now, this occurs by a negative feedback mechanism. During the first 3 years of life, the axial length of the eye increases, the cornea and the lens flattens and hence loses its power. After 3 years, that is 3 to 6 years, the axial length and the cornea stabilizes while the dioptric power of the lens continues to change. And hence, the normal visual acuity of a child is different from that of an adult, and it varies with age. At birth, they have a visual acuity about 6 by 120, and as their age increases by about 1 year to 2 years, and 6 years, they achieve the normal adult refractive status. It is important for us to know the visual developmental milestones of a child. At 2 to 3 months, they're able to fixate on a human face. By 3 to 5 months, they develop stereopsis. 6 months, they're able to focus on a distant object. And by 2 years, they're able to do tests like picture matching, etc. Now, it is important for us in refraction of children to assess the visual acuity of child. To assess the visual acuity of child, the techniques vary depending upon if the child is a pre-toddler, toddler, or a older child. So in pre-toddler who cannot communicate with us, we have to depend on their behavior, and therefore tests like cat-code drum, optokinetic drum, which assesses their optokinetic nystagmus, preferential looking tests like Teller's acuity, Diaz grading, we have to depend on, while VEPs are also a good method. Toddlers, you can use the miniature toy test, we can use the picture test, while for certain older children, we can use Landau-C, Snellen-G, Jogren's hand, Diaz symbol, etc. Now children have a very strong accommodation which occurs, and hence it is difficult for us to assess the refractive status. We have to use anticholinergic drugs which paralyzes the active accommodation. The drugs which can be used are atropine, hometropine, cyclopentolate. We can do an objective refraction by doing retinoscopy, for patients who are able to give us a subjective refraction, a post-mediatic test should be performed.
We are listening.
Drug which is used. Now, once you have assessed what is the refractive error, they should be treated. Not all the refraction errors, the refractive error in children need to be treated. We need to know now the chart on your screen is a guideline by AOA, which helps us to know when it should be treated. It depends on the error, the degree of error which is present in the child, if it is a myopia, if it is hypermetropia, or is it astigmatism. It depends if it is along with some ocular misalignment. It depends if it is anisometropic or isometropic. And hence you can use this chart to guide you to if it should be treated or no. All in all, we conclude that pediatric refraction is not the same of an adult as that of an adult. We have to take various factors into consideration, like that of the difficulty in communication with children, the fact that they have super active accommodation, the process of ease metropization has to be taken into consideration, age group, the ocular alignment of the patient has to be taken into consideration when you're dealing with refraction in that of children. And the go-to point here is that we should do a cycloplegic refraction in all the children, and that is a must. Thank you so much.
Yeah, good. Dilna, you should mute your computer, please. You're disturbing others. Judges, please go ahead.
Good morning, ma'am.
Yeah, you said you will use hometropine in children for cycloplegic refraction. You have mentioned in this. Is it effective? Hello. Again, her communication is lost, I feel.
Dr. Bansi? Dr. Bansi, please answer.
Did she finish in time, ma'am?
Yeah, she did. I think she did. Yes.
She was a bit upshoot, I suppose. Dr. Bansi, are you here to answer?
She got left.
Is the next speaker here, Dr. Shifa? Even she is not there.
Yes, ma'am, I'm here.
Where is Bansi? If she's around, you can ask her to connect with yours.
Yes, ma'am.
Is she available?
Oh, ma'am, I'm asking her. She's not around me right now.
So till that time, she can start her presentation, and if she comes around, then we'll ask her these questions.
Okay.
So that we'll not waste time unnecessarily.
Yes, sir.
Because this internet thing is going to be a problem.
So Dr. Shifa Waghu, she is from IMS and Badnapur, and she'll be presenting on newer IOLs. You can start your video, start your presentation.
Yes, ma'am.
Yes, support people, please start the timer. Go ahead. Shifa, start.
Yes, ma'am. Good afternoon and a happy Independence Day to everyone. My topic for today is newer intraocular lenses. My screen is not moving. So an IOL is an artificial lens which is implanted in the eye, which replaces the natural crystalline lens, which can be used during cataract surgery or refractive surgery. It has two parts, an optic and an haptic. An optic is the part which focuses the light on the retina, and an haptic is a filament which holds the lens in place. Sir Harold Ridley, who was an Air Force ophthalmologist, was the first who performed a successful IOL implantation in 1949. He used a PMMA lens, which was the first generation lens. After that, generation 2 lenses, which were early anterior chamber IOLs, which were angle fixated. Generation 3 lenses were iris supported IOLs. Generation 4 was the transition towards the modern AC IOLs. Generation 5 IOLs were improved posterior chamber IOLs. Generation 6 IOLs were the mature PMMAs, which were used for in-the-bag implantation, and the modern anterior chamber IOLs. And Generation 7 IOLs are the ones that we are using presently. These are the various IOLs that were used in the past. Recent advances are multifocal IOLs, which is a single IOL which has two or more focal point, which helps in good distance as well as near vision. It has three types. Refractive MIOLs have zones, 2 zones, 3 zones, or 5 zones, which help in correcting the distance as well as near vision. But these IOLs are pupil dependent. The diffractive MIOLs are pupil independent, and they have an anterior refractive surface, and the posterior has concentric diffractive rings. Apodized diffractive MIOLs involve both the principles, and they have a transition zone in between the two zones, and its advantage is that it has less scattered light and halos. Extended depth of focus IOLs are used in presbyopic correction. They have an elongated focus of vision, which does not comprise the distance as well as intermediate vision. The human eye has aspheric optics. The cornea has a positive spherical aberration. The young lens has negative spherical aberration. And as the lens ages, it goes towards the positive spherical aberration. So these lenses provide a compensatory negative spherical aberration, which helps in better contrast sensitivity. Accommodating IOLs move according to the contraction of the ciliary muscles, and therefore help in restoring the normal physiological accommodation. Toric IOLs are used to correct astigmatism, but proper positioning of the IOL is a must, because even 1 degree misalignment can cause a 3.3% loss of cylindrical power. Rollable IOLs are ultra-thin IOLs, which are rolled and put in the bag, and they gradually open up by warming up to the body temperature. Phakic IOLs are IOLs which are implanted without removing the natural crystalline lens. They can be used in myopia as well as hypermetropia, but hypermetropic eyes have more complications. There are three types: iris fixated, posterior chamber IOL, and angle fixated IOL, as we can see in the photos. Smart lens is made up of thermodynamic hydrophobic acrylic material. It is packed as a rod, and it transforms into a full-size bioconvex lens by the body temperature. Collamer lens is the most biocompatible IOL, and it has a monolayer of fibronectin on the lens surface. Aniridia IOLs are IOLs used in patients with aniridia or patients who have severe post-traumatic deficiency of iris. The center is made up of PMMA material, and it is surrounded by an aperture of black PMMA. Implantable miniaturized telescope IOL helps in restoring central vision in patients with ARMD, and it magnifies the central object.
Laser adjustable IOLs are used post-operatively as a laser is shot and it polymerizes the macromers. And lastly, we have the blue light filtering IOL, in which a yellow chromophobe absorbs the blue light, and as the blue light damages the retina by release of free radicals. Take-home messages: with the discovery of IOLs, visual rehabilitation is much better and quality vision is provided as close as to the natural vision. And advances are made to provide a good distance as well as distant, intermediate, and near vision. These are my references. Thank you.
Okay, over to the judges, please. She is overshot by half a minute, 40 seconds.
Shifa, do you know anything about a piggyback IOL?
Yes, sir. Piggyback IOLs are IOLs in which one IOL is placed on top of the other. The second IOL can be put in the same sitting or in a different sitting. Both the lenses can be put in the bag, or one can be put in the bag and one can be put in the sulcus. They are used in eyes which have higher refraction, which need a higher refractive correction.
Okay.
What will be the contraindications for multifocal IOLs?
Ma'am, multifocal IOLs, ma'am, if there is multifocal IOLs distort the view of the retina. So if there is a retinal pathology, we won't be able to clearly see, like, to monitor a patient with who has chances of developing a retinal pathology in the future. And they even cause a lot of glare and scattering of light. So in patients who work in these environments, we can it will be relatively contraindicated.
In a patient who he's an avid night driver, would you put a multifocal lens, or you will ask him to choose another different lens, and which lens will you ask him?
In night drivers, sir, multifocal IOLs will not be put because of the same scattering of light and halos.
Then which IOL you will, if he wants, I mean, relative freedom from glasses?
Relative freedom. Sir, he can opt for a foldable IOLs which we use in phacosurgery.
Okay. You will have to ask him to get go ahead with this. You said about the EDOFs, no?
Yes, sir.
So these are the lenses which are meant for such cases, you know.
Okay.
Similarly, okay.
You being an ophthalmologist, if you have to undergo cataract surgery, which lens will you prefer?
Sir, I will prefer a multifocal IOL, which will give me vision for both near vision, near, intermediate, and distance vision. It will help me in all the three.
Actually, it depends upon what age the patient is and at what point in your life you are undergoing the cataract surgery. So your priorities will be different in different points. Okay.
So can we move ahead? So I think Dr. Bansi is here, so you can ask questions to her. She had spoken on refraction in children.
I'm so sorry, I lost my Wi-Fi connection because of which there was an issue.
I had asked a question regarding to Bansi regarding, she said that she will use homatropine in children.
Yes, sir.
Yeah, you had mentioned in your talk, I mean slides.
Yes, sir.
Is it sufficient? And when will you use them?
So you can actually, atropine is a stronger agent as compared to homatropine, and for children who are below 5 years of age, we prefer to use atropine eye ointment. But for children who are above 5 years of age, homatropine can be used as the side effects also as compared to atropine is comparatively lesser, and it works for children above 5 years of age.
I thought cyclopentolate would have been a better choice in such cases because because homatropine will not completely antagonize the accommodative power of these children. So a stronger cycloplegic is required. Maybe you can say that atropine may not be used. Okay, I can understand that, but at least I would prefer to use cyclopentolate rather than homatropine in children, because we are talking of children, not any other category.
Okay. So some ophthalmologists do believe, and because cyclopentolate has a side effect of causing seizures or psychosis, because of which there are some set of ophthalmologists who prefer to use homatropine as compared to cyclopen, but it is cyclopen can be used too.
Okay.
Yeah.
Is there a role of fogging in
Yes, sir, for older children above 8 years of age, fogging can be used to eliminate the active accommodation in children. However, for children of younger age group, considering the accommodation is so high and quickly, by the time you're able to change the accommodate. So for younger children, cycloplegic will be preferable as compared to fogging.
Okay, good.
Yes.
Unmute Dr.
You're
Chabi.
not audible, ma'am.
If we have a 2-year-old child who has a refractive error of -3 diopters myopia, would you prescribe?
Ma'am, like I said in my during my presentation, that a lot of things have to be taken into consideration, the degree of error, which is -3. If it's a myopic -3, we can delay the prescription of glasses, because if the ocular alignment and everything else is normal, we can delay the prescription of glasses. It's not necessary, as according to the table that I had shown, the guidelines which were given.
And how often would you call this child for re-evaluation?
It's preferable that you evaluate a child who you think is a suspect for refractive error. Every 6 months follow-up should be done, at least.
Okay.
Yes.
So can we go ahead?
Yes.
Go ahead.
So I would now like to invite SCGMC team from Nanded, Dr. Saurabh Garud, and he is going to talk on biometry. So Dr. Saurabh, share your screen. And tech people, please start the timer. Go ahead, Saurabh.
Good afternoon, respected teachers, mentors, and my dear colleagues. Myself, Dr. Saurabh Garud from SCGMC Nanded. My mentor is Dr. Sohail Khan sir, MD, presenting you the topic of biometry. So what is biometry? Biometry is nothing but application of mathematics in ophthalmology. In ophthalmology, what is its role? The role is measurement of IL power in different situations. So how do we calculate the IL power? By measurements such as axial length, keratometry, anterior chamber depth, and lens thickness, and white to white limbus length. So in this, we are starting with the help of keratometry. What is keratometry? Keratometry is nothing but measurement of anterior corneal surface. So in this, we can measure it with the help of manual keratometer or automated keratometer. In manual keratometry, there is with the help of fixed doubling principle, the object size is fixed. We use the Bosch and Lomb, and in variable doubling, Javelin and Short's keratometer is used. It is two-position keratometry. In automated keratometry, we focuses the corneal surface, reflected corneal surface on electronic device, which counts the keratometry readings. Then after comes axial length measurement. In axial length measurement comes the ultrasound biometry and optical biometry. Ultrasound biometry is previous one, and latest one is optical biometry. In ultrasound biometry, there is the indentation one and applanation one, immersion one. In indentation, there is compression of cornea. So the axial length of the axial length changes, so does the IL power. So the immersion is always better than indentation one. So the new is optical biometry. It measures the axial length from macula, or from center of cornea to the retinal pigment epithelium. So it is more accurate. In this, we use the optical biometry such as optical low coherence reflectometry principle, partial coherence interferometry, and swept source OCT. In this swept source OCT is the best one. In this IL Master 700 is we use, but it is more expensive. So according to, we can use the immersion technique also. So the next one is the to calculate the IL formula. So there are 5 types of the calculation of IL formula. So first is theoretical formulas, then regression formula, this Verger's formula, then ray tracing, and then artificial intelligence. In theoretical formula contains the geometric optics of the eye is used, and it contains the Minkowski formula, Coley-Brander-Hofer formula, Gill's formula. In regression formula comes SRK 1 and 2. So we can use but it is more accurate for the normal axial length of the eyes. So the new formula, that is Vergen's formula, comes. So in this, there are, according to the variables, it is classified. It contains 2 variables, 3 variables, 5 variables, and 7 variables. In 2 variables contains Holiday 1, SRKT, Hofer Q. It is for shorter axial length optics eyes. Then 3 variable contains Haggis formula, Ladas super formula, and 5 variable contains Barrett's universal 2, and 7 variable contains Holiday 2. But the important thing is that Barrett universal 2 is the most widely used and accurate formula. It is free, available on apscrs.org website. The mandatory variables are axial length, keratometry, anterior chamber depth, and diffraction. Then comes the ray tracing formula, which contains Olsen formula, Oculix formula. Then comes the latest one is artificial intelligence based formula. Contains Hill RBF calculator, Kane formula, and Ladas formula. It is based on all the data which is present in our memory. Then comes the IL calculation in special situations like aphakia, pseudophakia, posterior staphyloma, microphthalmos, and post-refractive surgery. In aphakia, there is absent lane spike, so we can optical biometers are used. In pseudophakia, there is a high gain. There is extremely artificial spike, so we can reduce the gain. In posterior staphyloma, there is long axial length, then we can use optical biometry. In microphthalmos, change in corneal surfaces, so Hofer Q formula and biometry is used. And in post-refractive surgery, there is change in K values, so AC or CRS IL calculator can be used. Thank you, sir.
Okay. Over to you, judges.
Was he on time?
He was upshot by 11 seconds, 10, 11 seconds.
If you don't have any access to any modern optical biometers, most of the times you have ultrasonic biometry, which is usually used by all of the ophthalmologists, especially in the early stages. Which is the formula you will be using most commonly?
We can add 18 plus 1.25 in the what is the preoperative refractive error present.
No. For calculating the power. In case of a ultrasonic pachymetry,
SRKT, I can use SRKT formula.
SRKT. And for a myopic refraction, will you use any other formula or the same formula?
I can use Holiday 1 formula for myopic.
Okay. And in case of say all these modern gadgets, you have all the gadgets with you.
Yes.
Is there any role of manual keratometer to use? To get the K readings in this modern era? Is there any role of a manual keratometer which we used to use 40 years ago? Is there any role still? In any special circumstances?
If there is keratoconus or anything else, so we can.
What is that anything else? That is what I want to know. That anything else I want to know.
Sir, don't know.
Okay. In case of irregular corneas, say corneal scars, all these other optical biometers will not help and will not work to give you any K reading. In that case, you may have to use this manual keratometer for getting an approximate reading. That's all. I mean, you cannot get a proper reading in such cases, but any approximate reading can be had with this manual keratometers. Okay.
Yes. Okay.
What are the conditions where optical biometer you will not be able to get proper values in optical biometer, and you will have to use an ultrasound biometer?
In hard type of cataract, we cannot use the optical biometer, so we have to use immersion technique and other ultrasound biometry.
Hard as in
Dense nuclear cataract.
anything else?
Any other indication? Or using ultrasonic pachymetry where this biometers may not be useful?
Yes, this only I know. Hard type of cataract.
What about the PSC cataracts and a posterior polar cataract? Which type of biometer will you use?
We can
will
use
be useful. I would say will be useful.
We can use Swepser's OCT.
Okay.
Yes.
Any
That's
other
it. No question, ma'am. Ma'am, if they upshoot by few seconds, I mean, do we have to give either 0 or 1, or we can give in points?
You can give in points, sir. Other 10 seconds, so I think it should be counted. And more than that, then they should be given less marks. I mean.
Sure. Thank you.
So should we go ahead with the next speaker?
Yes, ma'am.
Go ahead, please.
Yeah, so we invite Dr. Anju Fogart, and she's from GMC Nanded, and she'll be talking on treatment of neovascular glaucoma. So Anju, please share your screen. Your screen's not yet seen. Yes, Anju, go ahead. Tech support, please start your timer. Go ahead, Anju. Are you muted? Are you muted?
Yes.
Go ahead.
Today I'll be talking about treatment of neovascular glaucoma. So first, to know the treatment of neovascular glaucoma, we should briefly know about the pathogenesis of the neovascular glaucoma. The main culprit being the VEGF, and followed by TGF beta and 1 and 2, following retinal hypoxia and ischemia, which further leads to new vessel formation and fibrovascular membrane formation, and later into open angle glaucoma, and later to angle closure glaucoma. In the treatment of neovascular glaucoma, we have three main principles. That is, first, treatment of the primary etiology, treatment of ocular inflammation, and treatment of the raised IOP. First, we'll go through the medical treatment. In this, we have intravitreal VEGF. The most commonly being used is bevacizumab at a dose of 1.25 mg per 0.05 ml. In this, we have, since IVP has a short lifespan, so multiple injections may need to be given. It basically reduces the load of VEGF and decreases the neovascularization. In the diagram shown, we can see the intravitreal VEGF being given through pars plana. Next, we have is anti-glaucoma medication. The preferred ones are topical beta blockers, oral and topical CA inhibitors, and alpha-adrenergic agonists. Next, we'll go to the surgical treatment. In this, we have pan-retinal photocoagulation. The pan-retinal photocoagulation is the mainstay treatment in case of neovascular glaucoma. It should be given aggressively and to be completed in a week's time in 2 to 3 setting with a follow-up period of 1 week. In the diagram shown, we can see the peripheral retina being photocoagulated, sparing the disc and the macula. Next is a trabeculectomy. If the new vessels have regressed and inflammation has been resolved,
there is a reasonable success rate of trabeculectomy if combined with mitomycin C. In the diagram shown, we can see the scleral flap being formed and a portion of trabecular meshwork and Schlemm's canal being removed. And the flap is resutured to create a new pathway for the flow of the aqueous. Next, we line is the glaucoma drainage devices. It basically creates a communication between the anterior chamber and the subtenon space. Examples being Molteno, Berwelt, and Ahmed. In the diagram, we can see the Ahmed implant being placed. Next, we have the cyclodestructive procedures. In the cyclodestructive procedures, there is transscleral cyclophotocoagulation, endocyclophotocoagulation. In this, the laser is being used to destroy the secretory ciliary epithelium of the epithelium, thus reducing the aqueous production. It is basically indicated in painful blind eye. In the diagram, we can see the endoscopic photocoagulation being done, and in this transscleral photocoagulation being done. Next week, this is the treatment protocol of neovascular glaucoma. In case of severe NPDR, PDR, CRVO, we should do a careful NTI segment examination. If there is early NVI, we go for panretinal photocoagulation. If there is florid NVI, we look for vision. If vision is present and vitreous hemorrhage is there, we go for vitrectomy plus endolasers. And corneal edema is there, we go for NT-VEGF and PRP. Media is clear, we directly go for PRP. If the IOP is uncontrolled, we go for trabeculectomy with mitomycin C and glaucoma drainage devices. If there is no visual potential, we go for cyclodestructive procedures. The take-home points would be elevated IOPs due to posterior peripheral anterior synovial formation. In case of sectoral NVI, we suspect intraocular tumors. In all stages of neovascular glaucoma, the PRP is the mainstay. PRP plus intravitreal bevacizumab is better than PRP alone. PRP plus retinal cryopexy and IVD is better than PRP plus IVD alone. Thank you so much. And have a good day.
Okay. She's very much in time. Over to you, judges.
In case of a neovascular glaucoma, what we call a painful blind eye, if there is no problem of visibility, then in that case, will you do, as you said, 360-degree cryo in one sitting, or you will require 2 sittings, and what are the criteria for this?
Sir, it's better to do in 2 sittings.
Okay.
And because if you do it in one sitting, the excess laser can cause a patient to go into phthisis.
Okay. That's good. And is there any role for any local bevacizumab being given in case of, say, neovascularization of iris?
Neovascularization of iris.
Yeah.
Yes, sir. Basically, the neovascularization of the iris is also because of VEGF. Since the VEGF from the vitreous can come in the NTA chamber. So, yes, VEGF has a role. It decreases the load of VEGF.
Okay.
Any other question for her?
That's it, ma'am.
Okay, Dr. Chami?
No questions.
Okay, so Anju, please stop sharing your screen.
Yes, ma'am.
So she was the last candidate, and we have judged 6 teams and 12 candidates. So students, I'm really happy with your presentations and hope you all also enjoyed preparing the presentations and presenting them here. So it was a good time practice also for you, and good presentations. And of course, thank you judges for judging, and wonderful questions, and of course, good answers by the PGs. So it was a great session all in all. So thank you, PGs. You can, I think, leave. And thank you, mentors, for mentoring all these students.